I'm a radiation oncologist. My name is Giuseppe Sasso, but everybody calls me with my nickname, which is Pepe. And I work in Auckland, New Zealand.
So, New Zealand is amongst the countries with the highest prevalence of breast cancer in the world, and the total number of breast cancer cases per year is expected to continue to increase. What do you think are some of the main reasons for this?
Well, I think it would be a very long question to answer, but to go very quickly is that unfortunately the incidence of cancer across all spectrums and including breast cancer is going up worldwide. So New Zealand is not exempted from the same trend. Also, we need to remember that we have quite a relatively young population, which is getting older, and so the incidence and prevalence are likely to go up.
Kia ora, I'm Libby Burgess. I chair the Breast Cancer Aotearoa Coalition, which is a coalition of patient-based breast cancer-focused groups across Aotearoa, New Zealand.
So, New Zealand has a robust breast cancer screening program. However, we've seen that actually 60% of diagnosis comes through non screening routes, such as self examination or a referral from a doctor. Why do you think this is, and how do you think the program could be improved to raise this target?
Well, the fact that 60% of our breast cancers are detected outside our publicly funded breast screening program tells us that there really is huge opportunity for improvement. Effort is needed to engage more of our women in the screening program, and this means that Breast Screen Aotearoa really needs to have more resources allocated. I think we need to establish an opt-out system where everyone is actually automatically enrolled and invited to participate in the screening program when they reach the threshold age, and then everybody should be regularly recalled to that program. We also need to expand the program to cover a wider age range. At the moment, it's 45 to 69, and we think that if it was expanded to 40 through to 74, that would save lives. There's good evidence for that.
I think there is already a lot of work that has been done to improve the program, especially at the level of cultural awareness and promoting the program across all pockets of population and all levels of individual and social circumstances. So, for instance, we are seeing some increase in the compliance to the program, but it's relatively younger than other countries, and therefore it's quite physiological that there is still room for it to get better. I think cultural and social awareness are probably the two factors that are going to play a significant role into this.
Maori women in New Zealand have a 60% higher breast cancer mortality rate than women of European descent. Why would you say there is such a disparity here, and how can this figure be improved?
The health system in breast cancer has been much less successful at engaging Māori women at pretty much every step of the breast cancer pathway. So this starts with awareness of breast cancer and the risks that it poses. The low success of the Breast Screen Aotearoa program at engaging Māori women in screening. And there's also evidence that fewer treatments are provided to Māori women, and the ones that are provided are done so more slowly. So this means that Māori women tend to have their cancers detected at a later stage when they're more advanced, and that combined with reduced provision of treatment and slower treatment means that there's a huge equity gap. So our Māori advisors tell us that the solution to all of this really is to empower Māori to engage their own hapu, that is their family groupings, and their iwi, their people and their communities in the health system. So local iwi-based solutions are really the key to unlock engagement, to make the health system actually relevant and geared for provision of services to Māori.
So, how important is patient-centered care for women who are diagnosed with breast cancer?
It is fundamental because the principle is you're not treating a cancer, we're treating a person. And so the continuum of care does not end with the treatment being completed, but only ends with a full return to form and to a satisfactory way of life for the patients who've completed the journey of care. Um, I think breast cancer is a great example of how, over many decades, we've gone from extremely invasive treatments, always implementing new techniques and strategies of minimal invasive technologies to and clinical approach to actually reduce the burden um, that patients have from their care.
In our report, we also identified the workforce availability as being a key challenge across all steps in the patient journey, as there is a shortage of specialists working in breast cancer care in New Zealand. What do you think is needed to develop, retain, and upskill the workforce here?
I think that the key to attracting and retaining great specialists is to build a culture of innovation. We need to invest in new technologies and medicines so that our specialists can be at the global forefront. But the current environment is one where rationing is the norm and we're lagging behind the rest of the developed world. We have a very low rate of participation in clinical trials, so our doctors don't get the opportunity to test breakthrough medicines and technologies, and patients don't get access to these until they're really well established in other parts of the world, and we may eventually acquire them later. So we need to aspire to best practice medicine. If we had specialist cancer hospitals undertaking research and development, we'd have a much more attractive country for the top minds in medicine. But of course, we also need to reward our specialists with attractive pay and conditions and provide access to the resources and the clinical support they need to be able to focus on their specialist roles. So that includes the nursing staff and other clinicians.